So we wanted to take this month, we've been with Simple QI for a year now. So we really wanted to look at our data. And so we wanted to look at, just do a deep dive into the data, see how teams are doing, see where we as a state could make some more improvements, see where we as the Department of Public Health and GAP-QC, how we can help you reach your goals, as well as you have the journey on the cardiac conditions of obstetrical care. So here is the GAP-QC maternal cardiac conditions key driver diagram. Many of you are familiar with this. As we support hospitals with bundle implementation, we want to call out the importance of the first key driver of readiness, in particular, establishing that multidisciplinary cardiac OB team, appropriate screening, and referral for pregnant and postpartum women. It is impossible to implement this bundle as a siloed group of clinicians. It is very essential that we work together to improve those structures that impact access and utilization of care. And you can see that the goal, again, is to reduce that severe morbidity and mortality related to maternal cardiac conditions in the state of Georgia. And our SMART aim is that by February of 2026, our hope is to reduce harm related to existing and pregnancy-related cardiac conditions through that fourth trimester by 20%. So for those that are currently working on the cardiac conditions, we know it's a big bundle. We know that there's lots of steps, and Rome wasn't built in a day. This isn't going to just be very easy work and take off. It's going to be a little bite at a time. And so just small little steps. And again, we have different levels of care facilities in the state. So again, some of these things may look different in different facilities. So if you are a level 1 and you want to, collaborate with other level 1 facilities, let us know. We can help make those connections there. Same for level 2 and level 3 facilities. The other thing is different EMRs, systems. We can help put you with your other EMR systems if familiar or similar EMR systems. We can group you together as well if you have things that you're working on at the same time that may be helpful. So we first just want to take a look at some of the process measures, and we're just going to look at the measures individually, the process and the structure measures. We want to make sure that everybody has a clear understanding of the measures, as well as give you a time to ask any questions about the particular measures that you may be having some struggles with or barriers to, and see if we can get any feedback from other facilities that are implementing this bundle as well. So this goes across all the AIM bundles, but the process measure is the provider and nursing education on respectful and equitable care. And so I've just taken this, and really in the reporting period, what cumulative percentage of your OB providers and nursing staff at your facility has received in the last 2 years an education program on respectful and equitable care. And this is a percentage-based report. So they're looking at a numerator as well as the denominator. And the goal for that is 80%. So out of all your total number of OB providers and nursing staff, how many of those in the last 2 years have received education on respectful and equitable care? So when we look at Simple QI and we look at our reporting, we can see the different reporting periods. And then we can also see at the bottom the number of teams that have reported that information. And this does go through Q1 of 2025 as of last week when I was pulling the information. So you can see that we are trending up very well. And at the moment, we do reach the 94.85% for the latest quarter. However, there's only 9 teams that have reported, and we know that we have 16 teams. And some of it may just be that they haven't gotten that information in yet. Some we know that if it hasn't changed, they may feel like it doesn't need to be reported. So we have talked with Simple QI, and we're trying to get some of these measures that maybe are not changing every quarter to see if there's a way that we could, keep the last data in, because some of it may just be, you've reported it hasn't changed, so it wasn't reported again. However, with simple QI, you have to report every measure every time that you report currently, but we are working on hoping to get some improvements there. So just some discussion around this. Again, one thing, house-wide education does count. Most hospitals, if not all hospitals, are required to provide that education on respectful and equitable care. So house-wide education does count. It does not have to be perinatal specific. So if there's any questions about that, or if anyone needs information or resources, reach out to us, let us know. We will be able to provide some of those resources for you if it's needed. But we did want to just clarify that any house-wide education on respectful and equitable care does count towards this measure. The second measure is standardized pregnancy risk assessments for people with cardiac conditions. Again, this is a percentage, and it is disaggregated by race and ethnicity. Again, you're looking at the total denominator would be the total number of patients with cardiac conditions that were diagnosed prior to that birth admission. The numerator is the number of those that did receive a pregnancy risk assessment. The goal, again, is 80%. Now, this is not the same as the screening tool. This is something that is done probably with the cardiologist, maybe with the OB physician, where this patient has a known cardiac condition and they are being given a risk assessment. Some of the ones that you may be familiar with are the MHU, the CARPREG, the Zahara. And so this is looking at the patient's risks related to their heart condition and if they were to get pregnant and carry a baby. So that is, I just wanted to clarify that with some of these. So this is patients with a known cardiac condition. So again, here looking at the data, we can see that we had an uptick. Again, out of 16 teams, we don't have all of those teams reporting. Again, if the answer to this is 0, that is acceptable. We want you to put 0 in there. One, it is a data point for us so that we can go back as a state and we can look and see, where the barriers are, what things that we can help work with. Also, it helps you as your team and your journey that you are able to go through and see what you have improved upon on these measures. So again, just some discussion around it. This is not the same as the screening tool. It is separate. And the classification of pregnancy risk is given for those patients with the known cardiac condition. So does everybody understand this measure? Dr. Cocky? Oh, I think you're on mute, Dr. Cocky.
Yeah, you're right. I was totally on mute. Can you hear me now?
We can.
Okay, perfect. Thanks. Sorry about that. I did plop the question in the chat, but one of the things that your question is really smart and is everyone kind of going through determining the denominator the same way? Because when you go back to the last slide, something that stuck out to me when we reviewed this, just looking at the number, like for example, the number of patients with cardiac conditions in Q4 2023 was 2,000. That seems pretty high, especially because there are only 2 hospitals reporting at that time. So my guess is there's a fair amount of variability. So I'm just curious if the hospitals that are reporting on this measure, if how they're just going about determining what their denominators are.
Can anyone who is reporting that measure, and again, I'll go back one more screen too. So the denominator of this would be patients with cardiac conditions that were diagnosed prior to that birth admission. And I know I've met with most of the teams, and we've kind of gone through each of the measures, and it may be that they were able to get a better understanding of the measure. It may have been a clarifying thing as well.
Well, and I think Dr. Cocker, to your point, that almost looks like a typo. I mean, if you look at it, looks like in the 200s, and then there's a 2000. Like there's 36.
I totally agree with you.
Mm-hmm.
But then along those same lines, it seems as though 0 out of 96 is probably also a typo. I'm just wondering, because if you're thinking about a person who has like a known cardiac condition, they're probably being followed by cardiology, followed by an MFM. They probably have a screener on file, or this assessment that is meeting the criteria on file somewhere, because they're hopefully most of them, if you have this diagnosis, you are getting additional like addressing it throughout the time of pregnancy. So I'm really just very curious about how people are even coming up with these numbers. Because I agree the 2000 is probably not accurate, but like how did we get the 289?
I will say for us, we had to go through a whole process to get it documented. I mean, we could assume it's being done, but does the OB see that the cardiologist has specifically done an IMHU or a ZARA or those specific things this measure is asking? And so we came up with a whole care plan and had some examples from other places. So it was kind of a process for us, at least I know. And I don't know if Ashley's on and can talk more about that.
And I know that some are having difficulty capturing this information because it usually is done outpatient. It's not being done when they're inpatient, because it's being done prior to that birth admission. And a lot of our data is looking at that birth admission. So Bridget, if I can set up a meeting with Ashley as well, but if I could get with your team maybe and get some pointers and how that process went and some of the things that y'all have been able to do, and then I could bring it back to the group and share with them later.
Sure. Yeah. And I think you just said it perfectly. It's about capturing it on the birth admission, because the idea isn't just that the cardiologist knows the IMHU risk or whatever they're using, but that the whole team knows the risk. And that was it. It was the finding it, capturing it, and know it's documented on every patient that does have a cardiac condition. Known cardiac condition.
Right. Dr. Bird?
I was going to just share too that when I see this, one of the things I think about, because I'm over our cardio OB team at Kennestone, is for the people who are sending in this data, it is hard for them to capture. And I bet, just like you were saying, like Dr. Kaki said, I bet the cardiologists are doing it, because to me, this question is whether or not they're assigning them like a WHO pregnancy risk classification, or like Dr. Schulman said, like a Zahara or CARPREG classification. I wonder if it would help us to, because I don't even do that in my own charts, right? Like I'll put it maybe in the note and I know it in the cardio OB stuff, but I'm not using it as a diagnosis code. So I wonder, could we maybe identify the diagnosis codes for those and send it out to the hospitals along with the list with the chart, like the chart I have in my presentations of the WHO classifications, right? And then maybe that would help providers to remember, please include their pregnancy risk classification now, that instead of just their diagnosis. So I just wonder would that help, because now I'm going to start doing it because I see this slide. But that's probably why they can't capture it, because otherwise whoever's capturing the data would have to know the condition, and then like they are not scoring them, so it's not happening, or they have to scour the notes to find it. So I think that would be helpful to let them know that maybe we should do it in diagnosis codes.
Yeah, I think that's also, and this is Bridget again, I think that's a great point. And I think when we first started talking about it, the OBs really didn't want to give the category. They're like, this isn't, I'm not comfortable assigning this category that's now going to stay with them. So they really wanted it to be a collaborative with the cardiology team, and then in a note that can be transparent and Stork with them and the team. So I'm happy to share sort of the template we came up with, and it also has the other recommendations. It's the MHU code, but also that's what we are using, but also other recommendations the cardiologist might want us to know. So it ended up being a care plan and this kind of at one time.
Yeah, Bridget, if you would share that with me, then I could get it back out to the different hospital teams. That would be great. Thank you. Okay, so we'll move on from that one. Our next one is process measure 2. This is looking at the multidisciplinary care plan for pregnant people with known cardiac conditions. So again, this also is a percentage and it is disaggregated. Again, your numerator is the number of multidisciplinary care plan, and the denominator is the number of patients with known cardiac conditions. Again, this is diagnosed prior to that birth admission. And then the goal, again, is 80%. So you're looking at how many of those patients with the known cardiac conditions that were diagnosed prior to that birth admission had that multidisciplinary care plan for the birth established by the time that they were there on their birth admission. And so again, we kind of have a rise and it kind of stays steady. Again, not all the teams are reporting. So again, if your answer is 0 because your team is not here yet in the process, that is okay. We want you to plug in 0 there. We want to make sure that we have 100% of our teams reporting. And so if there's nothing to report, there's nothing to report, and that's okay. Again, it's data for us. It helps us know how we can improve, what we can do to help you. And it also is good for you when you go back and you look and you say, oh, look at where we've come from, and how well we have done and what we have done to improve.
And Jennifer,
So,
I'm just add, this is where we slipped in. We made that care plan and added that code, the risk in that. So that was kind of knocking 2 birds out with 1 stone.
Perfect. Okay, great. And so again, this may look different in each facility. I know that some of our facilities are not going to be having patients with known cardiac conditions delivering in their facility. And so their numbers may always be 0 here, and that's okay. But Simple QI does have a spot that you can do annotations. So if it's the fact that you're level 1 facility and you may not have any of these patients, you can put a 0, and then you can just make a note that these patients, we don't keep these patients. These patients are always transferred to a higher level of care. Whatever. And again, we're going to work with Simple QI because if that's the case, then 0 is always going to be your number. We don't want you to get, fatigue having to put in 0 all the time. So it may be something that we can eventually have that will stay that way. So if there is no change from the previous reporting, it just carries over for you. So hopefully we can work on some of that as well. The next process measure is that the provider and the nursing education on cardiac conditions. So again, this is a percentage, and it's, have they received education in the last 2 years on signs and symptoms of potential cardiac conditions in pregnant and postpartum people. It is a percentage. And so again, you take the total number of providers and nurses as your denominator. Your numerator is out of those, how many have received the education in the last 2 years. Again, the goal is for 80%. And so we can see we had a nice uptick. We had a little drop back down, but we're climbing back up. And so we are there at that 80, right above the 80% goal right now. But again, we still don't have all of our teams reporting. So if there is a way that we can help you with some of that information, again, we have resources that are available that we can share. And again, it doesn't say that it has to be a formal type of education. It just says that they have received the education in the last 2 years. So this may be something that's quickly done at staff meetings, at huddles. It could be emails that you send out with red receipts so that you can track the information, and the ones that send you back red receipts, they've opened up that email. It can be one pagers. It can be something that is put in HealthStream where they're required to do that on an annual basis. So there's lots of different things. We have a lot of resources that we are willing to share and provide, as well as a list of resources from the American Heart Association, things like that. We can share those links. So if you need some help with this, please let us know, because we are more than happy to help provide that education, as well as provide those available resources for you. The next process measures is the emergency department education, provider nursing education. It's the same as the last one, except this is in your emergency room. Again, the goal is 80%, and we're looking out of the total number of emergency room providers and nurses, how many of those have received the education in the last 2 years on signs and symptoms of potential cardiac conditions. And so we can see we're kind of at a lull, and we've had a little bit of an uptick, and we've had the number of teams that have been able to report this increase as well. But again, I'll say it again, I'll probably have to say it with every slide. We want to make sure we have 100% of our teams reporting. And this, again, if it's zero, it's zero, and that's okay. We will be able to hopefully help you get those numbers up over time. So a zero is fine, nothing to be ashamed of. We just want to make sure that we're able to help you and be the best resource for you in the journey as well. So again, we have those available resources. Again, this isn't anything where they've got to come to class or a formal setting for hours on end. It can be quick, little staff meeting, huddle information. Again, the emails, one-pagers, HealthStream. And we have a lot of these resources available and, again, willing to share with you. And we do have some that are separate for the emergency department. It's a little bit more streamlined. We know they're busy. So process measure, this is one of the optional process measures. One, this is the cardiovascular disease assessment among the pregnant and postpartum women. So again, looking at the reporting period with all your birth admissions, it's a percentage. It is disaggregated by race and ethnicity as well. Your denominator is going to be the total number of all birth admissions. So everyone that was admitted for birth. Out of those patients, how many of those received that cardiovascular disease assessment? Again, the goal for this is 80%. And this is our data so far. Again, we can see that we had about 9 teams reporting this measure, but we kind of dropped back off to 6. I just don't know if that was because they hadn't gotten in their data yet. However, again, if this is still a 0 because your team is not there, that's okay. We want it to be in there as a 0 if you haven't been able. So just with the number of birth admissions, however many birth admissions you had, and then if you did not perform any cardiovascular risk assessments, then that numerator would be 0. And again, that is okay. So again, this one is different from the process measure 1 because that is for the pregnancy risk assessment with people with known cardiac conditions. And then this is for a cardiovascular disease assessment among all pregnant and postpartum women. So all birth admissions are receiving this screening. Everyone is probably very familiar with the screening tool. This is the one that Dr. Schulman and they helped with Hope for Georgia Moms kind of streamline out of the CMQCC, the California Maternal Quality Collaborative, with Dr. Hamid and all the work that they did. So I know that we have a good bit of people who are screening. Out of the ones of you that are screening, and you can put it in the chat if you want, you can come off mute if you want. Are you screening mostly in the postpartum period, or are you screening just when they come in? Some of them, I know from talking with the hospitals, do screen their antepartum patients, and then they also rescreen them in the postpartum. Most are not screening on labor admission just because with labor and pain, they're fearful it can change some of the things. So if you are you screening in your EMR, or are you still utilizing a paper screening tool? And if you could just type in what EMR system, if you are chart screening in your EMR system, what electronic medical record system do you use, whether it's Epic, Cerner, Meditech? That would be helpful for us to know as well, especially when we try to start connecting hospitals together. Okay, structure measure 1 is a patient event debrief. So during the reporting period, did your department establish or maintain a standardized process to conduct debriefs with patients after a severe event? Now, this one is a Likert scale, and so I have placed under here what that Likert scale is. So 1 is a score that indicates that this has not yet been started. And then 5 is that this is fully in place, and it is towards putting and keeping this structure measure fully in place. So on the Likert scale, and so we can see as a collaborative, we are at about close to 3%, or on the Likert scale, of our average is a 3. So we want to make sure, we want to try to increase that to a 5. And again, we want to make sure that we've got all of our teams reporting. And so if this is a 1 because your facility hasn't started this process yet, again, that is okay. We just need you to put a 1 down there for that. So again, around patient event debriefs, there are tools and resources that are available for debriefs. One thing I would like to say is that the debrief does not have to be led by a physician. It can be led by anyone who is comfortable in leading that. It does need to occur as close to time of the event as possible, just so that everything is still fresh. Oftentimes there are triggers that are in place that would indicate, okay, this is a case that needs to have a debrief. And so if you are doing those patient event debriefs, if you could share what would those triggers look like in your facility? I know some facilities do debriefs on all shoulder dystocias. Some do debriefs on patients who have to receive greater than 4 units of red blood cells. Some do it on low APGAR scores. Some do it on all hemorrhages. So what do those triggers look like for your facility? And you can come off mute. You can raise your hand. You can put it over in the chat. And then what is your debrief process? What does it look like? So for example, if you have a case and you have a case that has one of those triggers, then how does that debrief happen? Does it happen immediately? Is there a form that's filled out or completed? I know sometimes CQIRs get filled out, debrief processes don't happen. Those CQIRs get sent to risk management. And then it's weeks later, risk management contacts the people who were involved. And by then, some of the details may be a little bit foggy and not quite remembered. So again, if this is something that we can help you with some tools and resources, a trigger list of maybe what cases need to have those event debriefs, let us know, because we are more than happy to help you with that process as well. Structure measure 4 is patient education materials on the urgent postpartum warning signs. So again, this is a Likert scale, and it's just, did your department develop, curate, and or share patient education materials on those urgent postpartum warning signs that do align with culturally and linguistically appropriate standards? And again, it's on a Likert scale 1 to 5, 1 being that this hasn't been started, to 5 that this is fully in place. And so you can see that we've done very well here. But again, not all of our hospital teams are reporting. So please report this if you can. Yes, Dr. Kotke, round of applause for all the teams on this, because this is very important information. This is something that patients can take home, their family members can look at, because oftentimes I've had patients that have come back because of the warning signs. And they said that, well, my husband remembered that piece of paper, or my husband saw the magnet on the refrigerator, or a family member, and said, you know what, we need to call your doctor, or we need to go back to the hospital. So again, we have those resource materials available. They're also, the Peach cards for the cardiac condition specifically is also on the GAP-QC website. That is there and can be downloaded, printed, utilized. We also have other education materials as well. So any help that you may need with that, if you haven't gotten that started, let us know. But again, if you could all just report on that process. I know it's tiring always having to answer it, but again, we're working with Simple QI on that. So hopefully some of these, if you're at a 5, it will stay there, and you can just carry that forward. The next structure measure is emergency department screening for current or recent pregnancy. Again, this is a Likert scale, and it's looking at if your emergency department established or continued standardized verbal screening for current pregnancy and pregnancy in the last year as part of its triage process. I believe most of them are probably screening for current pregnancy, but we really would like them to screen for pregnancy within the last year. And again, this is that same Likert scale, with 1 being that it hasn't yet started, to 5 that it is fully in place. And so as a collaborative, we're sitting at about 3.5. So we can see that we have had that improvement from Q1 of 2023. We would still like that to increase and get a little bit higher. So if we can help provide some of those resources or provide some education for you to help you get your emergency department more involved, that's fine. We are also working on a 1-page poster signage from GAP-QC that can be placed in the emergency departments. It can be placed in triage rooms. Again, it's requesting that the patients tell the providers of their current or past pregnancy. So I think it kind of says something like, help us, please let us know if you've been pregnant and if you're pregnant or have been pregnant in the last year. So something along those lines. But that could also be put up there to help patients know that they also can speak up and say, hey, I saw your sign on the wall. Yes, I was pregnant, 6 months ago, had a miscarriage, or whatever the situation was. But we still want to know if they've been pregnant in the last year. Structure measure 1 for the multidisciplinary pregnancy heart team. Looking at this reporting period, did your facility establish or maintain a multidisciplinary pregnancy heart team, which can be comprised of team consultants that would be appropriate to your hospital's level of maternal care to respond to known or potential cardio-obstetric emergencies. Again, this is a Likert scale. 1, that it hasn't been implemented or started, or 2, that it's fully in, or up to a 5 where it's fully in place. Again, one thing I want to point out is this does state that this would be appropriate to your hospital's level of maternal care. So I know that some of our more rural level 1 facilities may not have that cardiologist in-house 24/7, but again, it talks about that team of consultants. And so, you know, if that process, you have that process down where you have these patients and you're consulting with those cardiologists, and there is that plan to respond to known or potential cardio OB emergencies, then that does count. Again, you're looking at that multidisciplinary team. So your anesthesia, your OB, your cardiologist, anyone else who you feel would be appropriate on your team. And again, this is appropriate to your maternal level of care. So here we can see that we kind of hover around the 3.5 up to about a little over 4%, but on average around 3.5 on this as a collaborative. So again, just ensuring that everybody understands the interpretation of the measure, and that you have that defined process or response in your facility, then that does count towards this measure and having that multidisciplinary pregnancy heart team. So if you're unsure, you can always reach out to us too, and tell us that process that you have, and then we can help guide you. Again, it is on a Likert scale, so 1 to 5, and then we can maybe help you kind of figure out where that Likert scale would be. And again, we want all of our teams reporting this. So if you want to reach out and tell us, okay, this is what we have, this is where we are with this, we can help you rate that, and we can have further discussion about that with you on a one-to-one basis. So here, looking at case reviews for the cardiac condition bundle. So has your facility established a process to conduct multidisciplinary systems level reviews of serious complications experienced by pregnant and postpartum people with cardiac conditions? Again, the Likert scale, 1 to 5, 1 being not started, 5 fully in place. I will say that some of the criteria for the multidisciplinary case reviews for the people with cardiac conditions would include critical care, ICU admissions for other than just observation, and then those at the highest level of risk, such as the MHU score risk levels of 3s and 4s. So those would be there for those multidisciplinary case reviews. And so here you can see as a collaborative kind of where we are with that. And so some people may be doing case reviews anyway and including these because they may not have met those criteria, but they may have been people with cardiac conditions but met other triggers that would trigger multidisciplinary case review. And so it may be that as well. But again, you may not have any. If you're that level 1 facility where you're not taking care of these patients, that they are being transferred to that higher level of care, then that's going to be 0 for you. And that's okay. Well, it won't be 0 because it's a Likert scale, but then we can talk about that and how that would be, maybe a 1 because that's not implemented. It's not going to happen. You're not going to have any of those. And then we can make a little annotation so that we know that those patients are not kept in your facility. And then again, looking at the triggers for those case reviews. So if anyone is doing this and is reporting this, if you would like to share in the chat any of the triggers for those case reviews, the triggers for the event debriefs, the process that you have in place for multidisciplinary case reviews, or if you want to put in the chat, hey, reach out to me because we have this process I can share, then I can reach out to you, or Rachel can reach out to you, and then we can get together and look at those things. So again, like I said, we really are here to serve as resources for you to help you with your journey. We want to make sure that everybody has the most opportunity for us. So to reach out to us. So I've included my email, Rachel's email, as well as Heather's email. We are the perinatal clinical team. And so we are here to help you on your QI journey. So if there's anything that we can do to help you, and then I'll leave it open to the floor. If you have any questions, comments, anything related to Simple QI, the data, the bundle, questions for each other. All right, and then while we're waiting, if anybody doesn't have anything, we'll just scroll back to the beginning. If you weren't on in the beginning, this is a new process that we are beginning to track attendance. We need to be able to report the data to our funding sources, but we also use information for your participation in our webinars and things like that for some of our GAP QC awards. Again, this is not in any way a punitive process or a way for us to track who is not participating in our calls. It is simply a way for us to report the number of people as well as the hospitals that are participating in our webinars. Some of our funding sources want numbers of participants, others want hospitals. And so this form will help us be able to put you with the right hospital if they're looking for hospitals. And Rachel has dropped that link in the chat again for you. So anytime you need to just scan this, fill it in. It's just the date, your name, and your facility. And yes, Latrina, I can. This is the annual conference in September for the Georgia Perinatal Association, and their QR code is there for that. You're welcome. And then there's the QR code for the Georgia A1 Georgia Section Conference that's being held in August at Lanier Islands. Yes, Dr. Kaki?
Look at, I even took myself off mute right away. I'm so proud. Thank you so much for going through that. I think that it was really helpful. I also just want to acknowledge that just the whole team for the journey we've been on to have something like Simple QI to be able to make the most of the data to help us be responsive to the data that we're seeing both at the hospital level and then at the collaborative level. So huge kudos to everybody and all the work that went into getting us where we are. So thank you. I do think that when we get to the space of being able to have those structure measures, like once you're a 5, you're always a 5, I think that's going to be huge. So fingers crossed on that. The other thing that comes up for me in this dialogue and a little bit in the chat is it does seem that there are some things that might be lower hanging fruit from the collaborative perspective. Like finding out what the debrief triggers are and sharing debrief tools. To me, that seems like a great opportunity for an upcoming, collaborative share out, if you will. Like, this is what we do. You want our stuff? Because that's how we help each other kind of continue to improve. Like, it's continuous quality improvement. So everything that we can do to help each other get better is what it's all about. So that one came up for me. And then there were folks in the chat who also described that they are screening, and it looks like they're screening both Northside and Cerner, and then Bainbridge in Expanse, which I'm not even familiar with. But that might be another space where we can really learn from one another. And then I'd love to hear the Northeast Georgia experience with how they are capturing I mean, because I think, Bridget, you talked about your two birds, one stone. I think that that's brilliant, and the extent to which we could have hospitals that don't have either of those birds taken care of, utilize your tools. I think that those were the kind of the three immediate next steps that came up for me when we reviewed these data.
I agree. And Bridget's going to share that tool with me. And so I can maybe set up a time. We can talk about it and we can share it with the other teams. I also put in the chat to please share your debrief triggers, tools, and processes with me if you want to email those to me or Rachel or Heather, and then we can help share those amongst the other teams as well. Any last thoughts?
Hey, Jennifer, it's Tara at Northside. How are you?
Hey, I'm good. How are you?
Good. Can you elaborate a little bit on what the GPA conference is? And because I'm not familiar with that. And so I was just curious.
Yeah, that is the Georgia Perinatal Association conference. It's a 3-day conference. It's mostly made up of nurses. However, we do welcome physicians, midwives, nurse practitioners, advanced practice nurses as well. But it is all related to maternal and neonatal care, so perinatal care in the state with Georgia. So we have the pre-conference is going to be a simulation training. It's 2 hours. So the first hour is going to be really looking at developing simulations and looking at the different, things that you need to develop a really good simulation. And then the next hour is going to be more hands-on with the different levels of fidelity, different mannequins, different things to do. And then we have some people come in to talk about pregnancy issues, neonatal topics, and then we're also going to have some simulations at the end for everybody who wasn't part of the pre-con, but they'll be separate from the pre-con, but they'll be towards the end as well.
Thank you.
You're welcome. Okay, well, if there are no other final thoughts, we will let you have about 7 minutes back into your day. We appreciate you all joining us and hope you have a good rest of your week. Thank you.
Thank you. Bye.